This presentation would show 16 slides. It describes applications of portable chest X-ray and ultrasound to assess lung damage in COVID-19. It would describe basics of X-ray and ultrasound along with imaging procedures. The slides will show lung abnormalities on chest X-ray and corresponding ground glass opacity on chest CT. It would demonstrate abnormal pleural lines, A lines, consolidation, and B lines on lung ultrasonography. The corresponding lung damage on chest CT would convince rationale and importance of both portable radiography and lung ultrasound to access lung damage in COVID-19. The following video describes how X-rays work.
Light is a form of electromagnetic radiation. At some wavelengths, it appears as visible light. At others, it takes the form of radiation we cannot see, such as ultraviolet, infrared, and X-rays. X-rays have very short wavelengths that, unlike visible light, are able to pass right through most tissues in the human body. Since bones contain calcium, a denser material than most other tissues, they are able to stop some of the X-rays and can thus form a shadow. If you place your hand in front of a flashlight, it will cast a shadow on the wall behind it. In a similar manner, X-rays directed at the body produce shadows on the opposite side that can be registered on film or on a digital sensor, so that bones are clearly visible while soft tissues, such as muscle, are shadowy. As a result, the two-dimensional images formed by the X-rays are quite useful in revealing structures within the body and can easily display fractures in bones.
As the global pandemic of coronavirus disease 19, COVID-19, progresses, many physicians in a wide variety of specialties continue to play pivotal roles in diagnosis and management. In radiology, much of the literature to date has focused on chest CT manifestations of COVID-19. However, due to infection control issues related to patient transport to CT suites, the inefficiencies introduced in CT room decontamination, and lack of CT availability in parts of the world, portable chest radiography will likely be the most commonly utilized modality for identification and follow-up of lung abnormalities. In fact, the American College of Radiology, ACR, notes that CT decontamination required after scanning COVID-19 patients may disrupt radiological service availability and suggests that portable chest radiography may be considered to minimize the risk of cross-infection. Furthermore, in cases of high clinical suspicion for COVID-19, a positive portable chest radiography may obviate the need for CT. Additionally, portable chest radiography utilization for early disease detection may also play a vital role in areas around the world with limited access to reliable real-time reverse transcription polymerase chain reaction, RT-PCR, COVID testing. Chest radiography is a less sensitive modality in the detection of COVID-19 lung disease compared to CT, with a reported baseline chest radiography sensitivity of 69%. The most common reported chest radiography and CT findings of COVID-19 include lung consolidation and ground glass opacities. Ground glass densities observed on CT may often have a correlate that is extremely difficult to detect on chest radiography. In Figure 1, portable chest X-ray with vague hazy densities in the right upper lobe, white arrow, which correspond to ground glass opacities, black arrow, on coronal image from contrast-enhanced CT, right, performed the same day. In Figure 2, portable chest X-ray with patchy peripheral left mid to lower lung opacities, black arrow, corresponding to ground glass opacities, white arrow, on coronal image from contrast-enhanced the contemporaneous chest CT, right. In Figure 3, often, reticular opacities accompanying regions of ground glass attenuation are more easily appreciable on standard chest X-ray. Chest X-ray, left, with reticular and hazy left lower lobe opacities, black arrow, in a patient with COVID-19. Similar findings are present on the coronal CT from the same day, right. In Figure 4, The hazy pulmonary opacities on chest X-ray can sometimes be diffuse, making identification challenging in some instances. Chest radiography, left, with subtle ill-defined hazy opacities in the right, black arrows, greater than left lungs in a patient with COVID-19. Findings are easier to appreciate on subsequent CT the same day, right. As opposed to community-acquired bacterial pneumonia, which tends to be unilateral and involving a single lobe, COVID-19 and other viral pneumonias typically produce lung opacities in more than one lobe. Identifying multifocal airspace disease on chest radiography can be a significant clue to COVID-19 pneumonia. Early COVID-19 investigators have noted that the airspace disease tends to have a lower lung distribution and is most frequently bilateral. In Figure 5, patients with varying degrees of COVID-19 pneumonia predominantly involving the lower lung zones, black arrows, bilaterally on chest X-ray. One of the most unique and somewhat specific features of COVID-19 pneumonia is the high frequency of peripheral lung involvement, often mirroring other inflammatory processes such as organizing pneumonia. Almost 40 to 86% of COVID-19 chest CTs had peripheral lung distribution. Such peripheral lung opacities also tend to be multifocal, either patchy or confluent, and can be readily identified on chest X-ray as shown in Figure 6, black arrows. Diffuse lung opacities in patients with COVID-19 have a similar chest X-ray pattern, see Figure 7, as other widespread infectious or inflammatory processes including acute respiratory distress syndrome. When lung disease involves the majority of the pulmonary parenchyma, patients are typically hypoxic and require mechanical intubation, see Figure 8. Lung opacities may rapidly evolve into a diffuse coalescent or consolidative pattern within 1 to 3 weeks of symptom onset, often peaking at around 6 to 12 days after initial clinical presentation, see Figure 9 and 10. Lung cavitation and pneumothorax are also rare findings in COVID-19 patients but can occur, see Figure 11. Localized large nodules have yet to be reported in the literature to this date, see Figure 12. In conclusion, patterns of COVID-19 lung disease can be identified on conventional chest radiography as well as chest CT. Typical verbiage when reporting patients with, or suspected COVID-19 on chest X-ray include terms such as irregular, patchy, hazy, reticular, and widespread ground glass opacities. Grading disease severity based on total lung involvement is also important to relay to the clinicians. As the pandemic progresses, the medical community will frequently rely on portable chest X-ray due to its widespread availability and reduced infection control issues that currently limit CT utilization. Following video describes basics of ultrasonography.
The heart of most ultrasound systems is a device called a transducer, which uses an array of piezoelectric crystals. A piezoelectric crystal vibrates when an electric signal is applied, producing high-frequency sound pressure waves, which we call ultrasound. More importantly, this type of crystal can also work in reverse. It can produce electrical signals when it detects high-frequency sound pressure waves. When a transducer directs ultrasound waves into the body, they pass right through the skin and into the internal anatomy. As the waves encounter tissues with different characteristics and densities, they produce echoes that reflect back to the piezoelectric crystal. This happens more than 1,000 times a second. Returning echoes are converted to electric signals, which a computer converts into points of brightness on the image, corresponding to the anatomic position and the strength of the reflecting echoes. A medical transducer contains a large array of crystals, which allow it to make a series of image lines that, together, form a complete image frame, called a sonogram. In addition, all the crystals are repeatedly activated many times in such a way that a complete image frame is formed around 20 times per second, so that real-time motion is displayed in the ultrasound image.
The following video describes basics of lung ultrasound for COVID-19 triage and monitoring.
South Korea's pandemic response system and medical equipment together have produced a cutting-edge front in the fight against COVID-19. Across the country, rapidly multiplying screening centers have helped flatten the curve of the virus. An important challenge has been identifying patients who develop pneumonia without displaying any apparent symptoms. With many such patients, Sonon, a mobile ultrasound device, has been used to measure the severity of pneumonia. This information remains crucial in determining the need for hospitalization.
엑스레이나 CT를 통한 폐 진단이 큰 문제점이 있습니다. 선별진료소에서 한 번 검사를 할 때마다 다음 환자의 2차 감염을 막기 위해 검사수나 장비의 방역을 시행해야 되는데 리소스도 많이 들고 시간이 소요되는 작업입니다.
So what happens that in pneumonia, the inflammation of the lung takes place. There is the accumulation of the fluid in the interstitial spaces. These are all the things which you can see in real time only with the help of the ultrasound.
Unlike bulky and wired ultrasound devices, Sonon is compact and wireless. This gives it a clear advantage in COVID-19 screening centers, where it can be easily wrapped in a clear disposal plastic cover. Once a test is complete, the plastic cover can be disposed of and a new cover put on to get the device ready for the next patient. This process significantly reduces the risk of secondary infections.
因为手到这个掌上移动超声啊，它这个疫情中的非常的便捷，非常方便，给我们提供了可以通过一些影像的信息来判断患者的病情的一个变化。
And then using the handheld devices for these examinations have their own particular importance because you are looking for yes and no answers. So from this you can understand that how important ultrasound plays a role in saving the life of the people.
Healthcare professionals around the world are having to use experimental solutions to respond to the greatest healthcare crisis of this century. And Heal Sarian is committed to supporting those on the front lines of humanity's fight against the disease.
Since the emergence of the severe acute respiratory syndrome coronavirus 2, chest CT imaging has been used extensively in the diagnosis and evaluation of patients. However, recent studies have recommended the use of lung ultrasound in the diagnosis and management of COVID-19. These studies have indicated that point-of-care lung ultrasound could be implemented as a substitute for chest CT scan. Although, lung ultrasound has several advantages including the absence of radiation, lower contamination risk, lower cost, and repeatability, one of its limitations is the relatively lower sensitivity in comparison to chest CT scan. Another disadvantage of this imaging modality is that ultrasound cannot usually detect lesions that are deep and intrapulmonary. A study reporting the ultrasonographic manifestations of patients with COVID-19 found that the most common findings are B lines, patchy consolidations, and unsmooth pleural lines. It has been reported that focal B lines are the major ultrasonographic feature of early-stage COVID-19 pneumonia. Since these findings are also present in other viral pneumonia, lung ultrasonography is not specific for the initial diagnosis of COVID-19. Based on published studies, the main finding in the chest CT scan of patients diagnosed with COVID-19 is ground glass opacity, a finding that is difficult to detect via lung ultrasonography. In addition, ground glass opacity is mainly observed in the posterobasal regions that might not be easy to reach for the radiologist performing the examination due to the patient's position at the bedside. Infiltrations detected by lung ultrasound can be suggestive of pulmonary edema, infarct, or lobar pneumonia. Nevertheless, a confirmed diagnosis of either of these findings requires a complementary imaging modality such as chest CT. It is observed that in critically ill hospitalized patients with COVID-19 who are admitted to the intensive care unit, ultrasonography may be helpful. Since these patients are at a greater risk of developing thromboembolic events and pulmonary thromboembolism, Doppler ultrasonography could be used for the detection of pulmonary thromboembolism in these patients. Moreover, ultrasonography could be used for assessing COVID-19 related complications, such as pneumothorax in those who are under mechanical ventilation or parapneumonic effusion in patients with superimposed pneumonia. Conclusively, we believe that ultrasonography may be helpful in COVID-19 management. However, its use in COVID-19 diagnosis and screening is limited, and so, chest CT scan remains the imaging modality of choice for diagnosing COVID-19. However, in places where chest CT scan is not feasible, lung ultrasound could be used as an alternative in the setting of the current pandemic. This slide shows lung ultrasonography and chest CT findings of a 42-year-old female with COVID-19. Lungs are divided into 12 regions in Panel A. In Panel B, it shows ultrasonography of upper lungs, multiple B lines, abnormal pleural lines and consolidations, white arrow, are shown in all regions. The air bronchogram can be seen in large consolidations in L3, L5, and R5, extremely little pleural effusion, red arrow, can be seen in L3 and R5. Chest CT shows patchy GGO with blurred margins in all regions, small patchy consolidations can be seen in R3 and R5, no pleural effusion was observed. Panel C shows ultrasonography of the lower lungs, multiple B lines and abnormal pleural lines are shown in all regions, consolidations or consolidations with air bronchogram can be seen in R2, L4, R6, and L6. Extremely little pleural effusion can be seen R2, L4, and L6. Chest CT shows patchy ground glass opsities with blurred margins in all regions, large patchy consolidations in L4 and L6 and large patchy consolidations with air bronchogram are shown in R6, no pleural effusion was observed. The following slides show lung ultrasound of healthy subject and COVID-19 positive patients.
This is a lung ultrasound. We are in a lung preset. We have rib and shadow, adjacent rib here and shadow, a nice thin pleural line with nice continuity, left and right sliding, indicating the absence of a pneumothorax at this level, and we see regularly spaced hyperechoic bright horizontal lines, which are A lines. These indicate reverberation artifact from a normal air-filled. This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We're in a lung preset. We see a rib here with a shadow, adjacent rib here. This is the pleural line, and we can see that it's thickened and irregular. There are B lines, confluent B lines here, an isolated B line emerging under this interspace, and some pleural thickening at the affected areas with some adjacent normal pleura and A lines. This is a lung ultrasound in a patient with confirmed COVID-19 infection. We are in a lung preset. We have rib and shadowing, rib here and shadowing. This is the pleural line, and we can see scattered B lines emerging from the pleural line as vertical hyperechoic artifacts, as well as a thickened and somewhat irregular pleural line with small subpleural consolidations. This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We are in a lung preset, and we see rib here with shadowing and adjacent rib here with shadowing. This is the pleural line, and you'll notice that there is some isolated B lines here as well as B lines there. During the sliding, you can see that there's thickening and irregularity of the pleural line with some discontinuity of the pleural line right there. And this pattern of thickened irregular pleura with scattered B lines and skip lesions where you have no B lines in this space between the two B lines is a characteristic finding that is emerging with COVID-19 infected patients. This is an ultrasound study using the lung preset where we see rib and shadow, rib and shadow. The pleural line has been obscured by the development of a subpleural consolidation with air bronchograms visible within this subpleural consolidation, representative of a focal pneumonia in a patient with confirmed COVID-19 infection. This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We're in a lung preset. We see a rib here with a shadow, adjacent rib here. This is the pleural line, and we can see that it's thickened and irregular. There are B lines, confluent B lines here, an isolated B line emerging under this interspace, and some pleural thickening at the affected areas with some adjacent normal pleura and A lines.
Lung ultrasound can detect changes in superficial lung parenchyma with greater accuracy as compared to chest X-rays and can, therefore, play an important role in triage, diagnosis, and prognostic stratification of patients in the emergency room and intensive care unit setting. Ultrasound findings in patients with COVID-19 pneumonia correlates with CT findings, which signifies that lung ultrasound could be useful for early diagnosis of COVID-19 pneumonia in patients presenting to the emergency room. Although most of the patients completely recovered from the disease, they are likely to have some kind of long-term lung damage. Only time will reveal the magnitude of irreversible parenchymal lung injury. Radiological findings are very helpful in predicting the clinical course of the disease and may be used to monitor long-term consequences. In conclusion, as the pandemic progresses, the medical community will frequently rely on portable chest X-ray and ultrasonography due to its widespread availability and reduced infection control issues that currently limit CT utilization. Assessment of organ damage in COVID-19 can also be done with positron emission tomography, magnetic resonance imaging and computed tomography. If interested, you may also review the following presentation. Presentation: Assessment of organ damage in SARS-CoV-2 infection with imaging modalities describes general information on source of SARS-CoV-2, diagnostic test available, drug development to treat infection, and 13 clinical cases where PET, CT, and MRI discovered organ damage in asymptomatic and symptomatic patients.